All right, we're back. So thanks, Simone, for that presentation. I think that's an excellent primer for the conversations that we're going to jump into. I certainly learned a lot already. Apparently sex is exercise, so if you can count that towards your 150 minutes a week, which is what the health guidelines say, I think that will certainly help. Okay, so we've got the rest of our panel here. So you've already met Simone. As I said, we've got quite a number of disciplines represented. We have Associate Professor Chris Barnes, who's the director at the Henry Ekert Haemophilia Centre at the Royal Children's in Melbourne, and has been in that position for the last 17 years. Can you hear us, Chris? He's there.
Loud and clear, thanks.
Thanks for being here. We have Alex Coombs, is a haemophilia social worker who shares a position at the Alfred in Melbourne. He's been a social worker since '97 in the field of sexual education and counselling. He joined the Melbourne Haemophilia social work team full-time in 2008. In 2011, he suffered a spinal injury and now has a permanent spinal injury, so has some very personal as well as professional experience in this area. Would you say that that helps you with your position, Alex?
Yeah, I think so. It certainly has changed my perspective in working in this field with patients, and yeah, I think it certainly has humanised me a little bit more, but it also gives the patients a bit more perspective that it is possible to be functional and return to work and to have an everyday life like you did before. So.
Brilliant. It's good to have you on the panel. And Penny McCarthy is a clinical nurse consultant at the Ronald Haemophilia Centre. How do you pronounce Sawyers? Sawyers.
Ronald Sawyers.
Sawyers. At the Alfred, Penny has extensive experience caring for people with haemophilia and other bleeding disorders since 1998. Is that right? You've been in the position. She's actively involved in nursing education nationally and internationally, and is a former co-chair of the Australian Haemophilia Nurses Group and former secretary of the World Federation of Haemophilia Nurses Committee, representing the Western Pacific and Oceania regions. Sounds like a lot of work. So that's welcome to all of our panel. We will dive into the Q&A. Just some further information on some of the resources that are available surrounding these topics. The World Fed of Haemophilia has an Ask Me Anything series on their website, which we did plan to play some of, but we're just working on the link. If you're interested in further information, you can go to their website, or you can Google World Federation of Haemophilia, or WFH, and Ask Me Anything, and there's a series of videos that concern these topics on their website. Okay, so we're getting a couple of questions coming through. We've got some of our pre-prepared questions that we will start with. Some are directed to certain members of the panel. Anyone who wants to jump in, feel free at any point, and we'll start working through them. The first one is for Chris Barnes, and it is, what are the most common questions you are asked about bleeds and sex, both from young men and women?
So I suppose reflecting Simone's comments that we're not very good at talking about sex, the discussion in the clinic room doesn't necessarily lend itself to, indeed the clinic environment doesn't lend itself to a detailed discussion about sex. It tends to be a high-paced environment where people are in and out, and I've got Simone ringing my ears that we need time to discuss it, and I think probably a natural reluctance on behalf of the patients and indeed the clinicians to avoid talking about sex, I think results in not many questions being asked about sex. The one that does come up is about psoas bleeds. It can come up from not typically the boys. All the boys are very quiet about sex, even though that, you know, natural exploration of sexuality and masturbation is all a very normal, healthy part of a healthy sexual life. It does not lend itself to too much discussion in the clinic environment. And I do, maybe just a brief anecdote is, we did go through a period of time at the Children's Hospital where we made a deliberate attempt to talk about sexuality and sex. And I clearly didn't have the adequate tools available, because it became a very confronting discussion, because all the boys knew that they were going to have the sex talk from Dr. Barnes. And so it just became a bit contrived and a bit artificial, and we decided to shelve it. So I put my hand up and say that I failed dismally, and I very much enjoyed Simone's talk, and hopefully I've got a few more skills available to embrace talking about sex, because it's a very important part. But the psoas bleed is probably the one that comes up mostly.
Yeah. Do you think that happens because they've obviously heard that from somewhere else, or perhaps it's happened to them and it's resolved, or
yeah, I think a combination of the two. So it is acknowledged that the psoas muscle is involved in the act of sex for boys in terms of the pelvic thrusting, and it's not, I sense it's not a particularly typical exercise, if you know what I mean. It might happen because of vigorous activity or something along those lines. And it is actually a very, as you know, Scott, it's a very challenging bleed to treat, and it can be associated with significant morbidity, particularly as it impacts on the neuroplexus in the pelvis. So it's a very important bleed to treat properly. So we know all about it, and I think maybe parents understand the severity of it. They know that it happens with sex, and so it's in that framework that it's raised.
Yeah, I think we should just clarify that a psoas bleed is your hip flexor muscle, and there's not a lot of tissue surrounding that, so it's very close to the bones in your hip, so can be easily injured, yes, by hip movement or from impact. And yes, the risk is that it's quite a big muscle, so there's always a lot of bleeding going on, and there are some nerves there, and there isn't much room for them to move. So a bleed can cause nerve compression and leg weakness. So it's one of the things that needs quite prompt treatment and medical attention from the Haemophilia Centre.
Can I just say on the back of that, Scott, that when someone's had a psoas bleed, there is that sort of awkward conversation that has to come up for the recovery, because if it's been significant, we're lucky here, our physiotherapists often have this conversation, but it's that conversation around that we need that muscle to rehab and not to rebleed, and that we're asking you to refrain from that same action, that same sexual action while it's recovering. But we don't want to turn these young boys off sex forever. We don't want them to think that they're never going to be able to have sex again. And that's where we've got to be very careful the way we navigate that field, especially when we first meet the boys here at 18 and we see neck call. We hear quite a we hear there's quite a lot of it's a high incidence of it in that age group because they're quite sexually active then, and so we just don't want to turn them off sex. So we've got to be really careful the way we discuss it and navigate that landscape.
Yeah, I think that's fair. And I know from a patient perspective, if you're embarrassed about describing how it occurred, you can be assured that we've probably heard it all before, and you're not the only one that it's happened to. And if you were embarrassed about how it happened, it's best if you can tell us. That's fine. Or if you want to tell us at a later stage, the most important thing is that you present and talk to us that it's happened. And yes, it's no big deal from our perspective anyway. Take myself off mute. We did have a couple of perhaps related questions come through. is there evidence to suggest that conversations about children improve comfort when talking about sex later on?
Can you repeat that? Sorry, Scott.
Yeah, I'm just trying to make sense of it. Is there evidence to suggest that conversations with children improve comfort when talking about sex later on? So perhaps having that talk initially.
Yeah, I can speak a bit to that, Scott.
Okay.
There definitely is there is evidence that young people who have a good sexual health education, and that's age appropriate sexual education, but not being withheld, kind of letting them know about their body, about consent, about what sex is and what it can look like, are actually, this is really interesting, are much less likely to engage in unsafe sex at an earlier age. They're much likely, in fact, the more young people know about sex and have had a chance to talk about it, the more likely they are to wait until they feel comfortable. So that's why I thought it was really important to bring that up in the presentation, where sometimes if children haven't and young people haven't had a chance to have good sexual health education, then can end up in situations where they're involved in sexual activity without a great deal of thought and preparation and time to get used to that idea beforehand. In terms of if you talk about sex as a young person and maybe it gets more comfortable, I don't know if there's research around that. I do know that my mum was a big one for talking about sex really openly at the dinner table, much to the embarrassment of all of my siblings and I, who'd be like, oh God, Mum, stop it. But I do think it has made it easier for me to have these conversations as well. But I think there's probably an element of personality dependence in there as well.
Sure, yeah. That might have helped you go into this field, maybe. Question for Penny. Simone talked about awkward conversations. I imagine you've had a lot of awkward conversations with your patients. What are some of the most common embarrassing questions?
There's three. We get a lot of calls, and we probably get a couple of calls a month on this, and they go, this is how they start. Because we're just to put a bit of, what we do is there's two nurses in the office at any one time, and the phone rings. And it goes like this. I need an urgent appointment with Dr. Tran. Well, I'm sorry, Dr. Tran's not here today. How can I help you? No, I need an appointment with Dr. Tran. Okay, I need some more information to see how I can get an urgent appointment for you. No, I can't talk to you, it's for Dr. Tran. So there's three reasons we get that. It's either there's blood in the urine, blood in the poo, or blood in the ejaculate. So at that point, I just say, well, are you bleeding? And they go, yes, I'm bleeding. Okay. Is it blood in your wee? No. Is it blood in your poo? No. Is it blood when you're having sex? Is it to do with sex? I'm too embarrassed to talk about this. And then first I just talk about, look, I understand it's really embarrassing for you, but it's quite normal. We have these conversations all the time. You're on the end of the phone. I can't see you blush. I'm on my end of the phone. You can't see me blush. I've done this for a long time. Let me see how I can help you. And usually after some conversation like that, the patient on the other end of the phone sort of settles down a bit, and we can talk about what their concerns is. And if it's something like blood in the ejaculate, which we do see a bit of, hear a bit of, we talk, it depends, very age dependent, if it's a one-off thing. So we talk about it and how it might have occurred and why it might have occurred. And then looking at the whole situation. So it's a very different conversation between like an 18-year-old, or if I'm talking to a 50-year-old man, where I'll say, well, look, if it's a one-off, let's watch, wait and see. But if it repeats again, we really need to get you in to see a urologist, because it could be due with your prostate, and we put the whole conversation around it. But I think the biggest part of all this is trying to, one, develop a relationship with your patients so they know you, they can ask you anything. And as we're talking, Chris mentioned, it's very hard in a clinic environment, but we have probably monthly contact with a lot of our patients, so at least they know who we are. And over time, if you, just the way you approach the conversation, usually we get around the end, get it, and get the, sorted out. And then, if they really feel uncomfortable, I'm only going to talk to a male doctor, I go, okay, it may not be Dr. Tran, but I'll find someone to call you, and we sort of work around it like that.
Okay, great, yeah. So it takes can take a bit of probing
Yeah, absolutely. But people are embarrassed. And the other thing, along with what Simone was saying, sometimes people don't have the words to use, and we need to give them some words to describe what's going on. Really.
Yes.
We may have to resort to perhaps what you'd call school playground language to help them understand what we're discussing. Yeah.
Oh, yes. Now you're speaking my language.
Yeah, you're speaking language, yeah.
I really liked, Penny, how you gave them options as well. So someone can just say yes or no then too. They don't have to actually say the words. Yeah.
You keep going until you find out. I mean, we had a boy that called us from Italy. This is the most wonderful story. And he called us and he goes, girls, because Megan and I were both in the office. He goes, I found love. I'm in love. I'm in Italy and it's the land of love and I'm in love. And we've been and I'm so in love and my foreskin's bleeding and I don't know what to do. And it was just the most wonderful conversation. And so we just started off going, well, how exciting it is you're in love. And, this is wonderful. And this is what we need to do with our foreskin. But it was rather lovely. So, but that's because we knew the kid and, we developed quite a relationship with him.
Lucky man. On that topic of potentially embarrassing questions, one from the group. Can you break your penis with sex if you have haemophilia? I'll open it up to the panel.
Well, I think maybe this is one for Chris, but I think penises are very hard to break. I think you can definitely damage any organ. And this is even for someone without a bleeding disorder. Sex can cause trauma to penises. And so it's worth thinking about positioning and force and also kind of thinking about, well, what am I trying to achieve here? Am I trying to just show that I'm a man, have an idea of what it is to be a man and this level of force is, or this amount of thrusting is what needs to be, because if we start thinking about the other person's sexual pleasure, depending if they have a penis too or if they have a vulva, then actually the types of things that might bring them pleasure are often not that, extreme in terms of physical effort. So, yeah, what would you want to add to that, Chris, in terms of breaking a penis?
Well, I've only seen one in my career, and it looked incredibly painful. So I probably also echo your thoughts for young men and guys, just to be careful with what they're doing with their penis. In terms of breaking it, I suppose it's not a bone, even though the colloquialisms might suggest that it is. It's not a bone, and it's a form of, there are sponges in the penis and they get engorged with blood under higher pressure. And so it's when a penis does break, it's a rupture of the connective tissue around the sponge that causes it. So it happens in men without haemophilia, with men with haemophilia, along the lines of what Simone was suggesting. So yes, it could happen. And if that was the case, I suspect it'd be a prolonged period of rest and rehabilitation and lots of factor, I would have thought.
Yeah. So I think to clarify, we're saying that it can happen to anyone. It's more serious if it happens to someone with a bleeding disorder and you need prompt medical attention. Do we agree? Excellent. Okay. While we've got you, Chris, there was another question directed your way, or anyone can jump in. What other ways can sex cause a bleed? I think we're piggybacking off the psoas bleed question, perhaps.
And Penny's alluded to it. It's hematuria, or it's blood in the semen, where small amounts or small tears in the lining of the penis and or the other parts of the urogenital tract can cause bleeding, and hematuria can be quite dramatic. A small amount of blood in the urine can look pretty awful if you're not used to it. And I suppose, again, just following on from Penny's and Simone's thoughts, is that we just try and normalise that. It happens, just let us know about it. It's not something that anyone's going to be too worried about, or if it's, particularly some of the younger boys who may be experimenting with their sexuality, we try not to make a big deal of it, to be honest. If it happens, we try and give the boys an opportunity to describe it if they want to. but we certainly don't put them under the spotlight and say, have you or haven't you, and keep on asking. That's not what we do. We treat it and just reassure them that any trauma to that area is normal, and this will get better. And along the lines of what Penny said, just try and avoid them feeling bad about it. You know, it's a normal, healthy part of life.
Yeah, I think that's really important, is to really reduce the shame around it so that people can come and get help without feeling ashamed. And I guess the areas of our body that are often, like I talked about the brain and the skin being so important, but the areas of skin and our, you know, our genitals and our mouths and our anuses and all of those areas that are involved in sexual play and sexual pleasure are highly vascular. And they do that, like exactly like Chris said, you end up with a higher pressure of blood during sexual arousal. So it is very possible that bleeds might occur in lots of different ways. And yeah, so I think that's exactly right. Like trying to reduce it. It's not an embarrassing thing that's happened. It's just like if you've been out playing football or something else and you've tripped over and something's happened. It's just as worthy of getting treated and being talked about as that.
We alluded to this a little bit, but is there anything else you can suggest to help the health professionals help their patients feel not so embarrassed about asking questions about sex or sexuality? Anything else? I think we touched on that pretty well. Does anyone else want to add in anything there? We did have a comment from the audience about the use of certain resources. So I think that's where you may direct them to the World Fed website as a starting point, just as a part of your general education, because there are some Ask Me Anything videos on there, like I said. Would we want to add anything else? More advice for the professionals who are working with.
It's interesting when you're mentioning about resources. I mean, those World Fed videos are excellent. They're very frank, very straightforward, and really good. But before we've only recently had those. People are often asking for resources, but they're actually asking for resources about general sex education. There are a lot of people that we see through here that don't have, much sex vocabulary or any just general information. They kind of want to read that they're normal. Then when you sort of explore a little bit more, they're actually, what they then are asking for is about sort of the genetics and then the risk of having a baby with haemophilia and things like that. It's often just the opener to a much bigger picture of their concerns. And I think that they come asking for that sort of thing. You need to not just hand them a book and send them on their way. If you can try and explore with them, how can we help you? It's often a bigger picture that they're looking at. There are people that really do have very little sexual education, or these days with Google, I reckon the kids are probably far more educated than we ever were. But it's sometimes they just want some basics, really.
And unfortunately, what pornography has done in our Western world has given a very dangerous view of what sex is. There's a lot of violence against women. There's a lot of manipulation of the video and of the bodies to make them look a certain way, and so people can have an idea of this is what sex is and this is what brings people sexual pleasure. And unfortunately, we know the statistics on young people watching porn are really incredibly high. Young boys often see their first pornography around the age of between 9 and 11. So it really influences how they develop if they don't have other sexual education coming through as well. So a lot of it might be, correcting someone's misunderstanding or a myth that's out there about sex. But I really think exactly what you said, Penny, that often the question, find out a bit more as a health professional, find out a little bit more about what they're actually asking and what their worries are, because there's quite a diverse range of questions people might have.
I think it depends where you are in the world as well, because I remember clearly one of the hardest conversations I've ever had, I was in the Philippines doing some teaching, and I was asked by this group of it was the support group, the Haemophilia, the foundation group, and this mother said to me, are the women in Australia promiscuous? I went, what? And it's what they were actually asking were the girls having sex before marriage, and then it worked out to be, could they be married? Because in the Philippines, they're girls that were carriers of haemophilia. They didn't want them to get married because they couldn't afford to raise a child with haemophilia. So if you didn't get married, you wouldn't get pregnant. Because if you weren't married, you wouldn't have sex, you wouldn't get pregnant, you wouldn't have a child with haemophilia. And that was a massive question. So I think we've really got to be sure. I mean, right now we're in Australia and we're talking about our cohort, but you've got to be very careful that you are, particularly in Melbourne's such a multicultural place, you've got to make sure you are embracing the culture of the person when they're asking a question like that as well.
Yeah, so true. And Alex, I'm interested to hear from you because you do some sexual health counselling. Like, what tips would you give to health professionals?
So I guess part of the questions are around being mindful around the background of the clients that we have. So yes, like Penny said, we have a multicultural patient base. We've got refugees from all sectors of the world coming through our clinics. So, they've got different religions to the rest of us. We've got to be mindful of those. We've also got to be mindful of the family culture. So not all families are really comfortable about talking about sex and anything in general, relationships and stuff. So when they come to see me, for instance, and they say, well, why would I talk to the social worker about my sex life? And part of that reasoning is about who you are and this is part of who you are and your functioning and your mental health and all these things that come into play. So I guess from my perspective, the questions are around what's your own relationship with your bleeding disorder, because we have a number of people that still have an internalized fears around having their bleeding disorder. They don't want it. They want to try and get rid of it. We have these conversations all the time. To then try and shift it to talking about their sex lives as well as accepting their haemophilia is a very complex thing and a very slow process that we've got to unpack. The other questions would, be around, does your religion have anything to say about being sexually active? Whether you're born as a Roman Catholic or as a Muslim, all these kind of belief systems are underpinning the way people behave and the way they think and they feel. So there's no right and wrong way, but it's a very slow process. It's not something, that can be done in a 15-minute consultation or half an hour consultation. It's something we've got to plan for, I think. It just takes a long time just to even build the rapport, to start the conversation. And as Chris knows, and everybody knows in this field, talking about our health in general, but our sexual health is not something that we do easily, and we've already said that, I think, from the outset. So yeah, it's a very slow thing, and there are other things that come into play that their experiences with HIV and Hep C in the past have influenced a number of our older population to some degree that they've chosen to abstain or have relationships, and it saddens me to think that's the way they thought they had to be. And to some degree, I think it's filtering still down to the younger population. Some people handle their haemophilia better than others, and whether that's a matter of their own education or their family upbringing or who they've been in contact with in the past, also I think will have a word to say in how they involve themselves in relationships and sexual behaviour and accept their own sexuality. I think the last 10 or 15 years, sexuality has gone to this big boom. It's not just straight couples, it's not just gay couples. There's this myriad of variations that we've all now got to try and understand. I've been in this field for 20 plus years, and I'm still grappling with the new terms that come out. The alphabet keeps expanding. You just used to be straight, lesbian, or gay, and then now it's something else. It's there's, I don't know, I think there's about 6 or 7 now letters added to that field.
I heard a great quote once, Alex, that said, "Nature loves diversity, but society hates it." Do you know, I think we've always been a myriad of things, but we've always
Yeah.
also liked to box and
Yeah.
understand. So I think
that's right.
people are finding language to explain how they feel. So I think it's exciting and yeah, it's an excellent time for people to explore that too.
It certainly is it's been an interesting area, and it's just something that, yes, I don't think people think of coming to the hospital and dealing with their bleeding disorder alongside with opening up the other parts of their lives that might influence the risks associated with having a bleeding disorder.
Yeah, and I think it's really, you know, we do provide holistic care, and we see people as whole people. It's very much stepping away from that old medical model of we just fix one thing and we don't see you as a full person. So I think
also from my perspective, some people say, oh, what's this old man asking me these sort of pervy questions? And I have to explain, you know, it's around seeing you as the whole person. And there's a part of the area that I'm particularly interested in, just ensuring that it is dealt with in a respectful manner, and one that is you're comfortable with, and you use your own language. As Penny said, you know, we've got to talk about this at the language that they understand. Whether we resort back to high school kind of thinking and language, I'm quite happy with it. I've heard it all before. You know, I think we've all heard some of it somewhere before, whether we're growing up with it. But yeah,
it's quite fun to use that language sometimes.
It is, and that's, you know, should be part of things to break the ice. It should be fun to talk about these things and make it easier for everybody so we all understand it.
We're getting some questions, which I think is good, from the audience. This can be to anyone. What advice would you give about masturbation, particularly for young kids? This might be a parent asking this one. I'm not sure.
I think it's pretty normal for kids to explore their bodies, and I guess as a parent, providing them guidance on where is safe to do that, you know, and teaching them about private and public space, and as I guess as a young person is, you know, going through their teenage years, knowing how they can explore their bodies safely is pretty important. I think, especially if there is an increased risk of bleeds, thinking about, you know, quite simple logistics like lubrication can be a great tool to kind of reduce friction, cutting fingernails, kind of making sure that giving permission to do this in a safe way. I think it's really important. One of those things of, if you don't understand your own body's pleasure, when you come to having partnered sexual activity, it's very hard to understand how your body experiences pleasure, to be able to share that with somebody else as well. Would you have any thoughts, Penny, as well?
I think as far as the haemophilia goes, on that, I think with this new landscape of treatment we've got, the most, I'm not saying all, here in this country, most kids have, I'm using kids old, anybody over about the age of, under the age of 40 is a kid. But anyway, the most young men are well covered with treatment. So sexual activity, whether it be on their own or with someone else, is a pretty safe time to do it now. Around their treatment is much more constant in their bodies a lot of the time now. So we're not seeing the problems that we had some years ago when we had very little treatment, and there was lots of times in the week when people didn't have treatment. We used to see the days when people would go onto prophylaxis, because we didn't have enough prophylaxis for everybody. So they would go onto prophylaxis for their wedding, or so they were covered for their wedding or their honeymoon, or they were going on a holiday, so they go on prophylaxis. And, I'm just like, it's great now that people have the treatment in their body, the medication in their body, to normalise their body enough to have, be able to do what they want, when they want, safely.
Brilliant. Okay. This one might fall on me. Can you suggest positions for people with very stiff joints? It can generally. The problem is that everyone has different degrees of joint stiffness and in different areas. I would say that something like lying on your back or your side would be the safest generally. But if you've got specific concerns, if you've got access to your haemophilia physiotherapist, they'd be a good person to ask about that if because it will be different for everyone. And you don't want to be causing joint discomfort with whatever you're doing. So it should be comfortable for you, just for the risk of flaring up arthritis if you've got stiff joints, or setting off a bleed depending on your coverage. So that will vary. So I can't give a specific answer for that, but if I suggest that if you're wondering about that, you talk to the physio that you have at your treatment centre. Another one is, anyone want to add anything there? Good. Another question, what can women do to manage mouth bleeds during sex? I think we might say how we might prevent them as well as manage them. Does anyone
taking tranexamic acid can be a really good idea. Tranexamic acid tablets, if they take that, if they're finding tranexamic acid's a really good drug. It's a very harmless drug. It's an inexpensive drug, and it's very good for mucosal bleeding, which is lining your mouth. So certainly taking tranexamic acid. And on the back of that, I know this sounds almost a bit gross in the spot, but make sure they've got good dental care, because with people who have plaque on their teeth will have more mouth bleeds. Any poor dental hygiene causes mouth bleeding. So you've got to have good dental hygiene. If you find it's repeating all the time, and it depends where the bleeding is, but certainly I think the tranexamic acid, it's on prescription, so you do need to talk to your doctor about it, but it would be a pretty safe and easy thing to do.
Okay. Splendid. Perhaps for the panel, if a man is having some problems with impotence and wants to do something about it, is Viagra okay? So I'd be guessing from the bleeding disorder perspective, you're asking that.
So I guess one of the first things is, if someone's suffering from impotence, there can be so many different reasons why this is happening, and it's really important that you talk to a healthcare professional about it, because it might be an early indication of cardiovascular disease. So there might be other things going on behind. So it's not immediately run to treat it. First thing is try and find out what's causing it. Kristen, you might be better to speak to this. I know that Viagra does have some side effects such as nasal congestion that can lead to higher increased times of nosebleeds. Is that something that you've come across too?
Not in the population that I look after.
Oh yeah, of course, because you're
Viagra tends not to be often a request in my clinic, the clinic I work in. But I suppose your point about just thinking of other reasons, I think maybe Viagra is seen as the panacea for erectile dysfunction, and I don't think there's any contraindications in the setting of patients with haemophilia, if that might answer the question. But I'd probably caution patients running off and getting it unless they've thought about the other reasons for erectile dysfunction, as Simone mentioned. I think
definitely worth getting. I remember a doctor once telling me that the penis is a bit like a canary in a mine, and if the mine runs out of oxygen, the canary used to go down first, and if there was no oxygen, the canary would die. So it's a bit like that. Those blood vessels in the penis, if they've started to build up with plaques and with those cholesterol buildups, then you might actually lose your erections, and it's an early sign that there's something else going on that could affect your heart. So it's a bit of a warning sign if there is erectile dysfunction happening, to go and get it checked out before you run to the Viagra.
A lot of not a lot. I mean, these days it's much better, but people on painkillers, that can cause impotence. We've had a lot of reports around that, but we get quite a few requests around Viagra. It was associated to. It says on the if you have haemophilia, you must speak to your doctor about taking Viagra, and there was all this work done around. It's had affected platelets, and they first thought it caused bleeding, and then they thought it was clumping, and then it's an increased risk of intracranial bleed. So in someone with haemophilia, that would be problematic. But certainly, I think Hugh Tran was talking today earlier about cardiovascular risk factors in older people. That's huge. You've got to make sure you're fit, which is what we're saying. It's there's a lot to it. It's not the magic panacea.
Yeah, but it is a vasodilator, so is it something, do we think we should recommend people talk to their haematologist about before going on?
Absolutely. Absolutely, because if you've had a previous cerebral bleed, it may even be a minor one, and you may not be for you, or you've already got hypertension, and then you want to add that into the mix. It may not be for you.
Okay, so it needs to be discussed.
Needs to be discussed.
Team.
Can I just ask a question? There are other forms of erectile dysfunction treatments, such as injections and other products other than Viagra. Does the rest of the panel know, is that also a risk for the bleeding disorder community?
I know with the vacuum pumps that
Yeah.
some people use for erectile dysfunction, it's pulling blood into the penis quite fast. So it has been identified as a risk again. And I imagine the same for an injection into that area of the penis. There is a chance that could cause a bleed. I think any of those treatments would need to be discussed in your particular circumstances and depending on what coverage you've got and what treatment you're on. So would you, Penny and Chris, would you agree with that?
Well, the pump reminds me of the ventouse extraction cap you use to have a baby with. I think, anything you pull blood into somewhere fast, I don't think, because people aren't covered up to 100% all of this. I don't know if it's the only thing you can use. I mean, there's not to say you can't use it. It just would take a lot of planning and a lot of discussion and how to do it in a safe fashion. So.
Vibration, though, is safe, and people find that sometimes helps with erections. I think a lot of people think of vibrators as something that work on a vulva or on a clitoris, but they're actually can be really pleasurable for penises as well. And there's vibrators that are designed specifically for penises. A lot of them are kind of shaped like a cup or either a half tube or a tube, and they can provide a lot of enjoyment as well and can help with erections, depending on what's going on with the erectile dysfunction. But they're a safe thing to play with.
Great. Alex, we might bring you in on this one. We didn't play the video, but we will play it at the end. The video that we will play talks about having conversations with your sexual partner before sex.
Yes.
This is important for not only preventing bleeds and injuries, but also for women if they have bleeds from the mouth or heavy menstruation. This can be awkward, especially if it's a new partner. And you're disclosing if you had a bleeding disorder. What do you suggest to deal with disclosure before sex with your partner?
I think we kind of started that conversation a little earlier, and I said that there were a whole range of background stuff that we'd want to think about and talk about to get to that point where they're ready to disclose their bleeding disorder or their own issues around sexual behaviour. And it's around, from my point of view, it's really starting at the base with the individual and where their level of comfort is and their experience. Thinking about your own ideas about what it is to be sexually active, around sexuality, and all these things would be part of the starting conversation, and then working towards practicing a script in their mind about who they're going to talk to this about safely, who and how they're going to frame these kind of statements. Often I say to clients, if you're uncomfortable talking to another person, maybe practice talking to yourself. And I often say to them, get yourself in front of a mirror and look at the way you yourself respond to these topics you're going to talk about with another individual. If you can't talk to your own self about it, imagine how uncomfortable it may be to talk to your potential partner or your potential love long-term relationship partner or whatever, or the one-night stand you might be thinking about having when you go out to the pub tonight or whatever, when we were allowed to go out to pubs, of course, in the old days, as it feels now. Yeah, so it's really starting with the individual and getting them to be comfortable with themselves first and brainstorming it and getting them to do a lot of, removing the thing from their head to their heart and how they feel. And that's where I would start for me with the client, anybody, male or female.
That's good advice.
There was a quite a physical bit of that question, which is about what you do about the heavy menstrual bleeding during sex. There are a lot of devices you can use, such as menstrual caps and things, menstrual cups. And if they talk to either in their, it doesn't have to be a haemophilia centre, about their women's health clinic about these things, there are devices that can use to, so the blood, to sort of cope, to fix the problems to start with.
Okay. At the Alfred, we're lucky we've got our social work position is job shared, and my offsider is Jane, who's obviously a competent female. So I have to say that my experience with talking to women is very limited and lots of fields, but we're lucky that we've got Jane on side. So if that topic did come up from a female perspective, we can always offer them Jane. So
yeah, I think that helps, having both a guy and a gal to share the load. We might, we'll try and play the World Federation of Haemophilia resources from their website now. We've got Tim from Tech Support who might be able to launch us into that. It's just a short 2-minute video. It's just one of a series of videos you can find on the WFH website. So I will see if this is going to work. Bear with us.
Okay, so for a person with a bleeding disorder, can sex cause a bleed? What should I do if one starts?
Yeah, thanks for the question. So sexual intercourse can potentially cause a bleed. Open discussion about what to do in the event of bleeding before sexual intercourse would be helpful to decrease the potential awkwardness of the situation. This will also help gauge the comfort level of those involved. For the receiving partner, if the vagina or anus is not lubricated or stretched properly, this can potentially lead to easier bleeding. For the penetrating partner, the more vigorous the thrusting, the more potential for bleeding, especially in muscles that are used for these motions. Caution should be taken for the penetrating partner as well, as penile fractures can also occur if the penis is bent in the wrong direction.
So if I feel a bleed coming on, is it okay for us to have sex anyway?
During sexual intercourse, you would theoretically have an adrenaline rush, which can mask pain and discomfort. Depending on where you and your partner are in climaxing, treating a bleed shortly after you've both climaxed would be reasonable if not too severe. However, if the pain is severe enough for you to recognize despite the adrenaline rush, then it could be a major bleed and it would be recommended to stop and treat sooner rather than later.
Okay, so yeah, there's a series of videos similar to what we just have seen on the WFH website. Google WFH Ask Me Anything, they will come up if you want to explore that further. We've got a couple more questions we can go through. Simone, you see a lot of patients with changes to their sexual function due to illness or chronic conditions. What kind of changes are common?
Yeah, so at the Austin, I see patients and clients that have maybe had a spinal cord injury or a stroke, or been through a cancer treatment, or are suffering from a degenerative neurological condition. And all of these illnesses and potentially traumatic injuries can have a huge impact on sexual function. You know, they can really impact physical nerve conduction, blood vessel flow. Like, there can be lots of reasons why the body doesn't respond in an arousal state in the way that it used to, but it can also be changes to how that person can experience sexual pleasure. You know, we know that the neurological pathways from the genitals and the skin to the brain can be interrupted. and can also be dampened by certain types of medications. So there can be times when people might not be able to experience orgasm. Their levels of sexual desire might be reduced as well, and those ability to get aroused in the same way. So there's this huge amount of physical changes that can happen, and it's very nuanced and personal to that individual. But then there's also the psychological and emotional impacts of how that's changed for that person. You know, whether it's somebody's lost a part of their body or lost sensation in a part of their body, or their body doesn't work in the way that it used to. And for many of us, there can be this way that we are sexual with partners, and we call it in couples, they can often develop a bit of a sexual script. I do this, you do this happens, we both feel good. And people can enjoy this level of pleasure, and then something happens and changes things, and their body doesn't work in the same way anymore, and they've got to adapt to that. And that can cause a stress on a relationship. It can cause, you know, someone to feel personally responsible or ashamed or not sexually attractive because of something that's happened to them. And so it can be a real mix of the physical and the psychological and emotional, and a huge range of diverse things. I mean, I think sometimes we can easily go, okay, well, I understand if someone has erectile dysfunction or prostate cancer, that's going to cause sexual dysfunction. And then you think about, well, if someone has a mastectomy for breast cancer, well, you know, is that really going to impact their sexual function? But we know that it does in so many different ways.
Excellent. And what kind of changes are common for older people generally? Do you see that?
Yeah, so I guess thinking about as we age, there's a whole lot of normal changes that happen to our body as we age. And sometimes people can see this as a dysfunction, but there's a lot of, this is just how things go. Everything slows down a little bit. Nerves don't transmit as fast. Blood vessels don't respond as fast. Hormonal changes happen. And that means that overall, it's quite likely as we get older that sexual desire can drop from what it has been when we're of a reproductive age, but doesn't mean that it goes away completely. And the body's ability to become sexually aroused is slower. And that, again, doesn't mean that sex can't be amazing and satisfying and pleasurable in so many ways. But there are some pretty normal changes that happen with aging. But alongside that, as we get older, our chances of other comorbidities, other conditions pops up, you know, more likely to have diabetes, cardiovascular disease. We might be more likely to be on medications that are impacting on sexual function. So there's those impacts as well, that we've got a body that's slowing down and not responding quite as quickly and in the same ways that it used to. But then we've got a higher risk of other things as well contributing. But we've really got to remember, though, that this doesn't mean that as people get older, that they're not sexual beings anymore. It might be different in the way that people choose to express that or enjoy sexual pleasure. You know, I have a very clear memory of when I started work as a sexual health nurse consultant. One of my first clients was a man in his late 80s, and he came in and, you know, he was walking with a stick, and he came in with his wife who had quite a few chronic conditions, and they both needed to sit down and catch their breath after making it down to my office. And he explained what the problem was. And she turned to me and she said, she was a lovely old Italian woman, and she reminded me of a nonna that lives near me. And she said, "Darling, I'm not dead yet. We need to fix this." And I love that story, because it really just breaks down that idea of if you looked at this couple, you weren't thinking about them having sex. You're probably thinking, oh no, they're well past that. But in actual fact, they were still being sexually active. And I think if we make that assumption about as people get older, or, you know, if people suffer from a disability, they're not going to be sexually active, where by those assumptions, we're missing out on offering people support and asking them if they have any questions about things as well.
Were you able to fix this?
Well, look, he was suffering from some erectile dysfunction, and we did talk about lots of different devices, and he was actually an inventor. And so, well, he was a self-proclaimed backyard inventor, and he went home and he actually made his own pump, and he came back and showed me, and I said, look, I really recommend that you purchase one of the pumps that's been designed. He said, no, but I found that, you know, those things that kids used to spray water guns with, he'd taken apart one of those. I don't recommend this. Do not try this at home. I think if you're going to use a device in any way like that, make sure it's of medical grade. And he agreed with me, but I was impressed with his ingenuity. So
very much so. What kind of issues might get in the way of intimacy? Shifting focus there.
So I think that there's, you know, like we're saying, there's so many things that can change in someone's lifespan, whether that's due to illness or injury or just their body aging, that can impact on how they're able to interact with a person sexually or enjoy sexual pleasure themselves. But for me personally, the thing that I've seen that most gets in the way of intimacy is expectations of what sex should look like. This is what should be happening. This is what I should be doing as a man, or this is how I should be as a woman. And I'm not able to do that. And so the people that I've met, people with quite diverse physical and mental and emotional challenges who've had incredibly satisfying sexual relationships, but it's been because they've thought outside the box and they've stepped away from this idea of sex has to happen in a certain way. And they've actually stepped into a place where they've gone, okay, well, what feels good? How can I enjoy my body? What is going to feel really nice? And, you know, there's actually, there's a sexologist in the UK called Betty Martin. And if anyone's interested in exploring pleasure outside of the idea of penetrative intercourse, look up Betty Martin's 3-minute game. It's really great. There's lots of resources on the internet about it. And it's about two people actually taking 3 minutes to say to the other person, this is what I'd like, this is how I'd like you to touch me. And there's a few different ways you can talk about it. And then 3 minutes is spent engaging in that kind of touch, and then that's reciprocated. And so it's really it's a lovely game to kind of step away from the idea of this is how sex should be. So I think, yeah, in terms of intimacy, it's letting go of expectations, letting go of that pressure to perform. I hate that, that word perform, because sex should actually be something that is shared and is mutually beneficial and is really focused on pleasure and enjoyment. And sometimes that pleasure and enjoyment comes in really unexpected ways and ways that aren't traditionally what we see as sex. I don't know if anyone else in the panel has ideas on what gets in the way of intimacy or...
Kids. Alex, you talked about conversations with partners. We've got a specific question.
Yeah.
But this is for anyone. This is from the audience. The first time I had sex with my partner, I had a mouth bleed and he freaked out. Do you have any suggestions for talking about it? Very embarrassing, exclamation mark.
Well, I think we have, again, gone, full circle around having a bleeding disorder and your level of comfort with having a bleeding disorder, and how you would inform your partner. Communication is a constant battle in any relationship. And it's not just about sexuality or sexual behaviour. It's about a whole range of things. And I think that the communication around disclosure of your bleeding disorder and what it might mean to you as an individual, but also how it plays out in any kind of situation and in the sex space is part of the thing that we wanted to talk about from the beginning. And finding words that we're all comfortable with, keeping it simple without dialing into medical terminology and that sort of stuff that everybody understands.
Do we have any specific tips for this person who's had an incident, I suppose, and obviously hadn't maybe talked about it prior to?
Well, probably to, I guess what Penny said before was also to talk to the medical team around these issues, and what treatment to be prepared for. That would be part of the thing, is to be prepared, whether it's around having treatment beforehand is one of the things that we would have to talk about.
Yeah.
I think also it's about what's your experience of reacting to bleeding. So if you've been brought up in a household where mum's always gone, oh my God, you're bleeding, oh my gosh, we've got to rush you, oh my gosh, you're making a mess, you're bleeding. There are people around like that. Or it's like, oh no, you're having another bleed, let's go clean it up, move on. It's how you're going to react when you bleed. So you need to, if you're bleeding and it'd be embarrassing. I mean, it's so embarrassing, whatever, with, your partner for the first time. So you're embarrassed about a lot of other things too, but it's just like, oh, sorry, this is part of my bleeding disorder. I'm going to try and do something about it so it doesn't happen again. It's revolting, I know, but it's just the way it is. It's just, if you've got to be accepting of the bleeding disorder to portray confidence in what you're doing. Otherwise, because you think you don't want this person not to to have a relationship with someone because of it.
Yes. Very good. Okay, well, we're almost out of time. Does anyone want to add any final comments before I wrap things up? I haven't had any more questions from the audience. So, yeah, if any come in the last minute, we'll add that in. But I think we'll finish it there. I hope people have gotten a lot out of it. Yeah, I guess the takeaway points might be that the staff at your haemophilia centre are quite willing and open to have conversations about this. It's maybe not easy for anyone at the beginning, but if you're asked these questions, don't be afraid to be honest. No need to feel embarrassed. And yeah, I suppose the more that the staff know, or the people looking after you, the more that they know, the better they'll be able to help you. So feel free to raise any topics that you may have. And we'll just say again that there's those World Federation of Haemophilia resources on the website if you would like to have a look at them. They've been developed specifically for these sorts of issues as a starting point to provide some background information. Okay, if everyone's happy,
Yes.
I think we'll finish there. Thanks everyone for attending, everyone on the panel for donating their time. Very, very helpful. I think people get a lot out of it.
Thanks, Scott.
Thank you.
Scott.
Bye. Thanks, everyone.
Yeah, thanks everyone for being there.